This is Dr. Curtis. I've got a live victim today. Someone close to me hurt her knee, and I'll use a pseudonym. We'll call her Jimmy. And I'm going to go through a quick assessment and see what that looks like. Okay, let's get started. Okay, here's the knee. Jimmy, tell me about how you hurt your knee.
I just banged it on the counter.
You banged it on the counter, okay.
Right on my kneecap.
And does it hurt right now?
No.
When does it hurt?
When I go up and down the stairs.
Oh, when you go up and down the stairs, okay. All right, let's take a look. So that's all I know right now. This is gonna be kind of the process of what a physical therapy assessment looks like. I banged my knee yesterday. There's no constant pain right now, but it hurts going up and down the stairs. Okay, on a scale of 1 to 10, when it goes up and down the stairs, how bad does it hurt?
5.
5. So you're saying it goes from a 0 to a 5-ish.
Yeah.
Yeah, okay. So that gives me a range. Alrighty, well let's look at active range of motion, okay? Straighten your leg out. So it's your left knee. And can you do that all the way without pain, or does it hurt?
No pain.
No pain. Okay, how about bending? Any pain there?
No.
Nope. Okay, let's do it a couple times. I always start with the patient moving themselves rather than going, does it hurt there? Okay. Good. Relax. Any problem?
No.
Okay, that's active range of motion. Passive range of motion. I'll let you do it, Jimmy. Go ahead and grab your knee and pull that back. That's flexion of the knee. Relax. Any discomfort or pain?
No.
No. Okay. So that's full range of motion with overpressure. So the knee joint is pretty much clear. So she banged her knee, so it's probably something superficial. So that's how we rule in or rule out things or gather information to guide our evaluation. So now I'm gonna test resisted structures. Push up against me and let me know if that causes anything.
No.
No. All right, go ahead and stand up for me. So next I'll do some functional testing. If you walk back and forth, does it cause any pain? Does walking cause any pain? Come back. Good. Okay, face me. Does that cause any pain? No? Okay, how about a little functional squat? Do a half squat first. Back up. Any pain?
A little bit.
A little bit. Where? Point to it.
Right there.
Okay. Give me a number on a scale of 1 to 10.
2.
2. Okay. Let me know if that gets worse. Certainly if it goes up to a 5, 6, 7, 8, let me know. We're going to stop the provoking exam. Okay. Squat down again. Do that a couple times. Is it getting worse or is it okay?
Same.
Okay. Can you go deeper?
Yes.
Hurt?
Same.
Same. Okay. All right. The last test. Okay. Fingertips on the table. One leg. There you go. Do a quarter squat for me. Any pain?
Same as before.
Same as two-legged. Okay, half squat. How's that?
Same.
Worse?
No.
No? Okay, down again. A little deeper. Good job. How's that? Same as a two-legged squat. And it similar to going up and down the stairs?
Mm-hmm.
A 2 or 10?
Mm-hmm.
Okay, good. Okay, you can sit. Now, after all that, subjective, active range of motion, passive range of motion, resisted test, functional test. Now I'm ready to maybe focus in and poke on a structure that I think is going on. And I know that her sins aren't that bad. What are sins? It's an acronym for severity, irritability, nature, and stage. Okay, stage, it's relatively acute, it just happened yesterday, but there's no constant pain. So severity, low. Irritability, as you can see right now, low. Nature, what's the general cause of the structure? It sounds pretty superficial. All right. So we're going to poke around what I think is going on. All right. So based on the exam, going up and down stairs, loading this joint causes some pain. So what do we have here? Bony structure. We got your femur on top, your tibia, and then your knee cap. Sometimes they call that the tri-compartment. Three articulations. When Jimmy did a squat or loaded that joint, it caused her pain, reproduced her pain. We call that the asterisk sign. What is that? We document that this functional activity reproduces her pain. And if we do an intervention, we sometimes go back to that and ask objectively or to see if the person's doing better, or even subjectively. How are stairs doing after rest, ice, etc., any interventions? So what do I think it is? What do you think it is? What's the mystery? We discussed, Jimmy has full range of motion, so there's probably no joint effusion or swelling in the knee that would bog it down. So twisting of the joint, she probably didn't do that. And that kind of rules out internal structures like your cartilage, ACL, PCL, cruciate ligaments, internal structures. So we're looking at extracapsular structures now. And it didn't hurt really with resistance, but it did hurt with loading. There's a piece of the puzzle. So it didn't hurt with quad loading. Let me do that one more time. Straighten out your leg. Scoot back a little bit. I'm gonna really load this. Hold it. Does that cause any discomfort or pain?
Nope.
Hold it. Okay, slowly lower as I do that. Hold it. Slow, 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 slow. Any discomfort or pain?
Mm-mm.
Okay. All right. So I am ruling out probably the possible, I can't reproduce a pain of her quad tendon, infrapatellar tendon. Okay, that's in the area. So we're looking at non-contractile structures. So it could be a superficial bruise, but loading the knee, the underside of the kneecap, what's called the patellofemoral joint, articulation between the patella and femur. So as the patella glides on the femur, that articulation maybe have compressed and have a little bone bruise or cartilage irritation. Probably the cartilage. Hopefully it's just that, not anything worse. Usually with the knee, where you poke, if you could reproduce the pain with palpation, that's the structure that's wrong with it. So Jimmy, let me know if we could reproduce the discomfort or pain. Or actually, let me ask you, point to the pain. Right about there?
Mm-hmm.
Okay. Can I reproduce the pain just by pressing on it superficial to deep, or is it deeper inside? Sorry, is it like a 2 of 10, 3 of 10, 5 of 10, 11 of 10?
1.
A 1, okay. So that's your pain,
Mm-hmm.
right there. This is similar to when you go up and down the stairs?
A little bit better.
A little bit better than going up and down the stairs? I would suspect that this is in the same area as you go up and down the stairs, because where I'm pressing isn't stressed hardly at all, or loaded. It's not stressed hardly at all when you go up and down the stairs. The articulation is actually underneath the kneecap. So, all right, I'm just about done with our examination. Now it's time for patient education and intervention, what to do for this. Probably have a superficial bruise. There are bursa here that can swell up. Your periosteum of your kneecap of any bone can cause pain. So that you probably have a little bone bruise right here, which is probably the least of your worries. You can put some icing, cryotherapy to decrease the pain and swelling. Probably the worst thing that is going on now when you do the squats, or if you go up and down stairs, you're loading the kneecap in gliding on your leg bone, your femur. The underside is lined with cartilage, hyaline cartilage, as it articulates your kneecap on your femur. So that underside hopefully is just bruised and will heal up fine. So the first key treating you, interventions, is figuring out what it is. So I think you have a superficial bruise that'll probably go away, and it might bruise up on you, it might swell up now that it's just 1 day old. The underside is probably the area we have to protect. So you certainly can get a fracture with this type of bang in your kneecap, and if that were to happen, your pain response would be much higher. It would be much sharper with stairs and loading your knee joint, with squatting, getting up for a chair, etc., and the test that we did here. So what can you do for it is a certain amount of rest. Since you said stairs irritate it, loading the knee certainly puts pressure on the knee. So you can do what's called a wedding march, okay? So the painful limb is here. You could have that one do a half step. So instead of 1, 2, like this, you could do 1.5, like this, okay? So my right side is doing the majority of work, and this one's just kind of doing a half step. So that's how you can rest it. Going down, people actually bends the knee more and actually tends to hurt more. So this is the painful one in question, the left. I actually want to go down with the painful one. Watch. See this? It's relatively straight, and my right leg is eccentrically lowering me to the step. And you could, again, do a half step like this. So this is what we teach people in the hospital all the time. Up with the good, down with the bad, okay? And up with a strong leg. And down with the hurt leg. Down with the bad. Up with the good leg. Down with the bad. Why is this important? Because if you forget and you come down like this, look how much loading and bending there is of the hurt leg. Okay? And there's actually a lot more bending than actually going upstairs. So people will say going downstairs is worse. Okay? So this is how to rest it, and it'll make it more tolerable and hurt less and get better faster. So anyway, Jimmy, thanks for letting me use your knee. Thanks for watching. This is Dr. Curtis, Digital Doctor of Physical Therapy. We'll see you next time.